Good day everyone, I am Michael, the moderator for this webinar. I welcome everyone for today's webinar, which is CMS Hospital QAPI Standards 2024. It's a great pleasure for me to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, BS, JD, RNCH, CP, HRM, was COPIC's Director of Facilities Patient Safety and Risk Management and Operations from 2014 to 2020. Ms. Dixon has over 20 years of clinical experience in acute care facilities, including critical care, coronary care, perioperative services, and pain management. Laura holds a Bachelor of Science degree from Regis University, recipient of Denver, a Doctor of Jurisprudence degree from Drake University College of Law. I would now like to hand over the floor to the speaker. Over to you, Laura.
Okay, thank you very much, Michael, and I hope everyone can hear me clearly. As Michael mentioned, we're talking about QAPI, Quality Assessment Performance Improvement. Now, I want to do a brief introduction on why we're here, and no facility ever wants to receive one of these. How does it work? With the changes going on, you want to make sure you're keeping up. So if this is you're in compliance, this is your role. The conditions of participation, the manual part we're talking about, first came out in '86. You can see here, these are all of the items over which CMS has responsibility. And this happens to be the index for the acute hospital. You will see the last update was July of 2023. Transmittals. And that's what that would look like. And I just do a screenshot for what the survey memo site looks like. This is the topic we're talking about, QAPI. Real quick on deficiencies. These are the deficiencies for QAPI. For QAPI, there were many changes with CMS, and it was through the Hospital Improvement Rule back in 2019. Now, the formal name is very long. I've got it here, the regulatory provision to promote program efficiency, transparency, and burden reduction. The overall benefits were they were trying to reduce burdens to the providers for quality and QAPI. One other item that came up from this rule talked about system-wide. And the interpretive guidelines, the rule itself didn't include them. Those didn't come out until March of last year. There's only 16 pages of this material. So the reason they put this out for these guidelines in particular, we're going to be looking at acute hospitals. That's primarily. Why do they want to do it? Why is QAPI so important? There are 11 tag numbers total. The focus is really to determine, do you have an effective ongoing system in place? Now, there are some key points here. So the key points here. All right, so for the standards themselves, I'm going to start with those. The governing body, they have to make sure this program works. Now, I put the new guidelines in here. They expect you to continually study and improve your processes and service delivery. It doesn't tell you any particular program that you have to use. They want continuous data collection. Other expectations. Under contracted services, this is in tag 83. It's in the governing body section of the manual. The surveyors, they won't judge your performance and the measures you used. They will determine if you have an effective ongoing system to look at those problem areas. They may look at other areas. I want to talk about a little bit what the surveyor should not do, but with a caveat. Oh, protected records. This one just came up recently. So just be aware they will ask for copy of your program documents, and it talks about your patient safety organization work product. So in a nutshell, this memo, and you say, yes, I'm part of a PSO, but you can't prove it. The program has to include continuous collection and analysis of the data. The quality indicator data should be those from adverse events. If you have the data there, use it. In analysis, you should be able to show your indicators that you used. That shows measurable improvement to outcomes. CMS won't tell you the thresholds for your improvement. There has to be evidence the body had an active role. Now, this is from your QAPI staff. Now, this is new. They want evidence, the frequency, and detailed data. They'll make sure that the hospital, again, through the governing body, is using that data to look at other opportunities. So just some questions when you're looking at your scope. There's outpatient quality measures. Other examples, utilization management. Your restraint seclusion, one of the highest rated areas for deficiencies and citations. Patient flow issues, timing of antibiotics. Use the data to identify those opportunities. Take actions to improve what you're doing. The guidelines call upon the hospitals to look at their program data. Look at your high-risk areas. Problem-prone areas, handoff communications could be another one. And recent ones that you put into place, they'll talk to your governing body, your staff participating, and reporting them. Now, these guidelines are very long. They're new and it's very long. I've hit on some of the key areas here. Now, CMS in their definition, they adopted from the Quality Interagency Coordination Task Force back in 2003. It can be a medication error. Maybe it's an infection control or sterile processing. Then they define a near miss. An adverse event is preventable. That's one. Injury was caused by an error. After you do your analysis that you identified the cause, then you got to take action. Surveyors will ask for evidence of your reporting system. You do have to conduct your projects. The number and scope, that's up to you. The QIOs, or Quality Improvement Organizations, you can participate in one. In the new guidelines, they gave us some definitions. What and how many, that's up to you. Always keep your records, at least 6 years. Be able to show what projects and the activities you have. What do they entail? They want a list of your distinct projects. From the governing body, the board has to make sure the program reflects the complexity. Again, executive, they have full responsibility and authority. Leadership is responsible and accountable for this program. The responsibilities, you have to make sure standard requirements are met. The governing body must make sure that those services are done safely. Other evidence, again, with the contractors, the governing body does have a lot of responsibility in keeping an eye on them. So that's why they need to be qualified to perform these functions. So here's some examples of adequate resources. The surveyor wants evidence of the resources you did provide. All right, briefly on Unified Integrated. You have to have policy and procedures that make sure each hospital or location are given consideration. All right, as we start to wind down, I do want to just go over critical access hospitals. Again, there were changes in 2019, the burden reduction memo. They put in new tag numbers. You have to demonstrate evidence that it is an effective program. Scope, complexity, but they are responsible and accountable to make sure the program meets all the requirements as far as scope and design. And there are resources specific for critical access hospitals. All right, QAPI and event reporting. Again, you are required to track your events. So just in summary, your governing body, they have to make sure that the program is implemented and it's effective. Review your plan annually. National Quality Forum, great resource, tools and resources. And so I want to thank everybody. Michael, thank you for your assistance. And for those of you who listened in, I hope it was helpful and beneficial. And thank you. And everyone be safe. Michael, I'll let you close us out.
Thank you so much. So that does conclude the session for today. Thank you everyone for participating. You may all disconnect now. Have a great day ahead. Bye-bye.